commission meeting. This is a hybrid commission meeting, where several of us are here in room 100. The rest of the commissioners are participating by Zoom. The ground rules for a hybrid meeting continue to apply. I will have a roll call of commissioners at the beginning of the meeting. I ask that commissioners and presenters identify themselves before speaking, so the commissioners and members of the public will know who's talking and will have the same knowledge as those of us here in room 100. Commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. To minimize background noise, I ask commissioners and presenters to mute their electronic devices when they're not speaking. And I also ask commissioners attending remotely to avoid putting comments in the chat because it can be difficult for those of us in the room to see those comments. MHCC posted documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We'll continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. Okay, I'll call the roll now. Commissioner Bandari?
Here.
Welcome, sir. Commissioner Blake?
Here.
Welcome. Commissioner Boyle? I can see you. Welcome. And Commissioner Brzezinski?
Here.
Welcome. I don't think she's here. Commissioner Cheatham? She said she could not come. Commissioner Douglas? Come back to Commissioner Douglas in a minute. Commissioner Gilroyd?
Here.
Welcome. Commissioner Gilmore?
Here.
Welcome. Commissioner Jensen? I can see you. Welcome. Commissioner Ojikutu? Commissioner Spinner, I can see you. Welcome. And I believe Commissioner Duncan is going to join us late. But Commissioner Duncan, are you on yet? I think she'll be joining us later in the meeting. Commissioner Wang?
Here.
And Commissioner Wood?
Here.
Welcome. And Commissioner Douglas? Let's check it again.
Believe Commissioner Douglas was going to join, but the staff can maybe check on that, see if he's having trouble logging in.
In the meantime, we have a quorum, so we can proceed. Good. We have two items on the consent agenda. First is the minutes from the June 2024 Commissioner meeting. The second is the action on project change for University of Maryland Medical Center Adolescent Inpatient Acute Psychiatric Unit. Does any commissioner wish to remove either of those items from the consent agenda? Okay, hearing none. Is there any objection to adopting the items on the consent agenda? All right, without objection, the consent agenda passes. On to item number 2, update of activities. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Commissioner Boyle.
Yeah, I just want to underscore on page 11, the healthcare associated infections chart that's included. Long-term healthcare worker flu vaccination, 2019, 2024. I'd love to hear a comment on what we're doing, what the commission is doing to better kind of publicize this information and perhaps improve education, and somehow the hospice is doing much better than some of the other areas. The home health is doing the worst in terms of vaccination, which I think is a patient safety issue. So if we could comment on that.
I'll ask Teresa to comment.
Thank you, Commissioner Boyle, for that question. The staff is putting together a presentation for September to talk a little bit more about flu as well as HAI in general. But I'd like to ask Stacy Howells if she has some comments to make.
So we have, as you noted, the hospice has increased significantly. So I think it's important to note that hospice has gotten better. And we have recently expanded to hospice and home health. So I think it's important to note that most states aren't collecting in those two areas at all. So I think it's important to note that we do have that information, that other states don't have that. Also NHSN, that is a new endeavor for us where we are collecting the data, the flu data from nursing homes through NHSN. And that's been a big undertaking to get all nursing homes signed up through NHSN and to get the data from them. And now what we're gonna do is we are taking the data from NHSN and we are publicizing the information on our quality reporting website so that consumers have the information so that they can make better decisions on how to choose a healthcare setting for their loved ones. And then we also share that information with the Medicaid program, Pay for Performance program. And that helps create an incentive for the nursing homes to improve. And so those are some of the ways that we're trying to help improve.
If there's anything else you think we could be doing.
We are trying to think of some other ways to help improve as well, but still we're trying to think of some incentives, like the Pay for Performance program.
Yeah, before you leave, Dr. House, I did see that nursing homes vaccination levels have declined since the pandemic. Do you think that's related to just general vaccine antagonism or suspicion? Or is it related to NHSN? But in general, it did seem like most of the nursing homes compared to their levels pre-pandemic actually saw declines, or many of them did. I don't know if that's an observation you made as well, but I was curious about your thoughts, maybe to the point that Commissioner Boyle made.
I don't know if it has anything to do with NHSN because that just started this year, so I don't think we can attribute anything to NHSN. But anecdotally, it possibly does have something to do with vaccination fatigue. But other than that, we don't really know. But anecdotally, we've heard some comments.
Are there any, because this seems like it might be a national sort of issue, is there any kind of national source on people reluctant to take the flu vaccine because of general vaccine concerns or anything like that?
Just vaccine fatigue is pretty much all we've heard.
Sometimes, I think sometimes he does do the appetizer.
Yeah, that's what Jerry told me that.
And then everybody get drink and everything.
Whoever's talking, could we go on mute, please?
Yeah. So that's what I was told, so just let me know.
Okay, I'll ask him this.
Oh, I thought somebody was asking a question, sorry.
I think that was the question.
Okay.
Are there any other commissioners with questions? Ben, do you have any additional?
So, thank you, Chair Sergeant. Before I begin, I wanted to make an announcement to make commissioners aware that our chair was recently named General Counsel for Care First, and a job well-deserved, but we hope that it doesn't deter him from anything he's doing at the Healthcare Commission, but certainly we all would wish him congratulations. I did note that he was wearing a new pair of shoes today, so I'll leave that up to him, but congratulations, Randy.
Just because you haven't seen them before doesn't mean they're new.
So on other notes, I just wanted to be sure we again emphasized lots of activities going on. First off with the AHEAD model, which everyone knows stands for States Advancing All Payer Health Equity Approaches and Development Models. It's quite a mouthful. I think AHEAD captures what the objective is here. We have had conversations with the Health Secretary regarding our role. She's emphasized in terms of the primary care implementation of the model. She believes NHCC could play a role. As you know, we convened the Primary Care Investment Work Group already, which sets targets for primary care spend among the commercial payers and hopefully soon for Medicaid as well. There's also increased reliance on the APCD, the All Payer Claim Database that the Healthcare Commission assembles. That will be one of the tools for benchmarking progress. And here we'll be talking about more timely consumption of the data. We receive data quarterly, but its usefulness doesn't really come into play or at least 6 months after the data is submitted. We want to accelerate the ability to consume and analyze that data moving forward over the next couple of years. And also, we want to start to fill out a significant gap in the APCD. Like other states, Maryland is not able to collect information from self-insured employers, which constitute about 40 to 45% of the commercial market, as well as we are not able to collect information, oddly enough, given we're in a federal model, from federal employees that are insured through the Federal Employee Health Benefit Plan. Both of those represent significant shares of the commercial market in Maryland. And we are looking at ways to collect that data that would not conflict with the ERISA preemptions that exist today. One avenue we are pursuing is trying to collect information through what are called electronic claim clearinghouses. David Sharp's talked about those repeatedly, but it might be a vehicle that through which we could assemble some of the data that's currently missing. More to come on that as we work through changes to our regulations over the summer. The primary care efforts will resume on August 21st, when we will have a joint meeting of not only the primary care investment work group, but also the MDPCP Advisory Council, another group focused specifically on the evolution of the Maryland primary care program, and as well as the primary care work group that the secretary convened to talk about recommendations the primary care community could make as we put together a formula proposal. This will be a large group, probably 70 participants if everyone attends now in late August. It might not be as well attended as later in the year, but I think we're looking forward to a kickoff and having all members. There is some overlap among the three groups attending. I note that Dr. Buzinski and Dr. Cheatham are members of one of the groups. Dr. Buzinski, MDPCP Council, Dr. Cheatham, the investment work group, and we look forward to their participation, as well as any other commissioner who would like to attend to let us know. We'll make sure that information's out there. Also wanted to talk about some of the additional studies that we were assigned. They kept rolling in. And as you know, even as late as the end of June, we were getting some additional assignments. A study on the role of private equity in the Maryland insurance market we were directed under language in the non-compete legislation that passed the legislature to study private equity. We were also directed to hire a contractor to help us. We put that forward through a procurement that's now on the street. We're looking for, ideally, we would like to have organizations that are not necessarily affiliated with firms engaged in private equity or venture capital. But we obviously are in the early stages of that competition. We'll see how proposals coming to the commission, and we'll evaluate them quickly but fairly, so we can get this work started. That work is due to the legislature by the end of the year, which is a pretty aggressive timeline for a study. I would note that the FTC and Department of Justice have had a rather lengthy RFI process at the federal level. And some of that information does really emphasize the importance that many in the healthcare community see in the increasing involvement of private equity, to a lesser extent venture capital, have in healthcare. It is my perspective that we have to look at this carefully, that you don't want to paint all firms with the same broad brush. And the alternatives in a healthcare system that does require significant investment means that we have to look carefully at what the sources of investment are and what the alternatives are, because oftentimes today, small practices, as Dr. Buzinski would certainly emphasize can be challenging to exist. Secondly, we are also asked to look at market concentration. This was sent to us in a letter. It's in my mind, they could all be combined, but we've elected to the request from the chair of HGO is to look at market concentration as it pertains to payers and to a lesser extent healthcare systems. That will be issued through a separate procurement and will focus a little more directly on issues specific to Maryland related to the payment model and payer and health systems participation in that. That too was due by the end of the year. We've requested that be extended through next summer to reflect the fact that it's we too are going to use that for a competition. But I think clearly what you're getting is a flavor for this greater awareness of who's involved in the control, and particularly of physician organizations, but also some significant challenges on reimbursement. And there's still more. We are been asked to do a study on whether the non-par payment formulas for HMOs need to be redesigned. We plan to do that internally. But the feeling of some in the provider community is that it would be more beneficial if the formula for HMOs was better aligned with the similar but not identical formula that applies to the PPO payment or providers. They're somewhat different and the reference points are different. I think it would be beneficial that they be aligned, but we will ultimately pass the information to the legislature and they'll make that determination. Lastly, a couple updates on regulations. I know that in particular, Commissioner Boyle usually asks me about what the status is of the nursing home regulations in relation to the law that was passed in this session, Senate Bill 1000. Can't quite remember the House version, but anyway, they were adopted. We were directed to have regulations in place by the end of the year. The law actually becomes effective in October, but we are well on our way to developing a draft that we plan to, using a technical term used here frequently. We're going to float these regulations formally to the stakeholders. Based on the level of comments that we receive, we'll make a determination at that point whether a formal work group is needed to go through other ideas before we bring back the regulations as proposed regulations early in the fall. The goal is to try to meet this deadline of having regulations in place by the end of the year. And lastly, on regulations that you hear regularly, health HIE, Health Information Exchange Regulations, 1025-20, or excuse me, 1025-18. Those regulations, recall we did the work on HB 812, which are pertaining to reproductive health. You'll hear more from David and Anna later on in the session, but we are also focusing on 3 initiatives that were adopted in the 2021 session that focus on consent management. There is consent management. There's consent management features in most HIEs, but they are not well integrated across the HIEs. So if I, in particular, want to opt out, I may have to go to several HIEs, EHRs to selectively say, I want to opt out here, I want to opt out of there. The first step is to develop an integrated health consent management function in which a patient so disposed could opt out of multiple HIEs at the same time. Moving forward, the evolution of that is to have a much more granular consent management feature where patients can selectively opt out of certain types of information sharing for certain types of services, but that is moving further down the line. Secondly, we will also be focusing on implementing the controlled dangerous substance provisions of legislation passed in 2021. Currently, as many of you know, there is a requirement that pharmacies have access to prescribing information for controlled dangerous substances. The same framework could be incorporated for non-controlled dangerous substances, which would be very valuable for care management, public health purposes. But we have to modify our regulations to accommodate that. We are moving forward with that. There are some technical challenges associated with that, but we believe it's very doable. And the good thing, I think, is that the provider community is well aligned and in support of that endeavor. And lastly, as I mentioned at the outset, we do need to consider how we augment the APCD, and that third leg of the regulations will focus on how we might collect information, claim information as it flows from providers to payers through health information for electronic health networks, not HIEs, but through what are called claim clearinghouses, and how that information, some of it flows back from the payer through the clearinghouse to the provider, which largely pertains to information that the payer would add, in particular, payment information. The statute as it exists really gave us the ability to direct CRISP to collect information on these transactions for public health, new care management initiatives. And we're looking at that broad authority to cover the activities we're doing under HED moving forward. But that's going to be one potential avenue that we're going to have to look at in order to fully develop the all payer claim database, given the Supreme Court rulings in 2016 that limited states' ability to collect information from ERISA plans directly. So that concludes my update. I do want to note before I conclude that we do have the former chairman of the Maryland Healthcare Commission, who I think just simply dropped in, although there may be another purpose. I want to welcome him and of course, thank you for his service and note that he's probably here for some other purpose.
You can work the gavel.
So happy to take any questions.
So one question is, we have about 8 reports at the end of the year. So they're all targeted for delivery by December, which means that there's going to be a lot of report reviewing in our future as we head into the fall. So is there an overall plan that we could put out for the commission members to, steal ourselves? How many times?
I think that's a good point. We have an internal schedule for it in terms of the deliverables from staff, but we can share that with when you can expect to get drafts of documents. The good thing is some of the work, as expected, David's already well ahead of his schedule, and we have a couple pertaining to the recommendations on the adequacy of payment for telehealth and audio only services. That was a legislation that passed in 2023. We also have a report, again, done by the same vendor that will provide information on adequacy of payment for behavioral health and primary care. That is also based on legislation that came out of 2023 that we'll be dealing with. Also note that Tracy and her team is working to complete the behavioral health workforce assessment with the aid of a pretty seasoned contractor based out of California. That should be ready in the early fall, I would expect. But a formal schedule of events, so to speak, is something we'll provide in several weeks.
I think that would help the commissioners because these are important topics. They're very meaty. Big contribution by this commission to what the legislature's working on.
And the focus is there.
There will be some staggering involved.
We'll be staggering to get them through. Broadcast. Yeah, I think there'll be 3 that are going to be coming out fairly quickly. These drafts. I have a couple of them already in my inbox myself.
Right. Are there any other questions for Ben? That, we move on to agenda action item number 3.
So before I end, I did, state, or forget to, note that, Ruby Potter, who's been a longstanding, employee of the Healthcare Commission, will be retiring, in August. I want to recognize her mighty contributions to the health planning function over nearly, 3 decades or more. And she'll be sorely missed, but we wish her all the best in her retirement. Thank you, Ruby. Annie Hawk has another announcement. If you can come up.
Yeah, I wanted to introduce, as a staff person that you know for the last year is the acting the acting chief of Certificate of Need, Jean Marie. Where's Jean Marie? Will you come back, come up here? So Jean Marie, she has been with the commission since 2019 as a program manager and has been the acting chief of CON. She comes to us with a bachelor's degree in interdisciplinary studies that includes gerontology, women's studies, and theater. She has a master's of arts in theater, as well as a master's in gerontological and healthcare administration studies. Before coming to the commission, Jean Marie worked for 20 years as a healthcare administration, as a nursing home administrator, as a hospice administrator, as well as a home health administrator, and a regional director of a CCRC. I'm pleased to announce that Jean Marie will stay with us, and she will be the new chief of the long-term care policy and planning division within my center. So she brings a wealth of knowledge, and I'm very excited that she's staying with the team. So just wanted to.
Thanks, all. Bye-bye.
Thank you, Ben. Agenda item number 3 is a CON exemption for the University of Maryland Rehabilitation and Orthopedic Institute and University of Maryland Medical Center. James Lawrence Kiernan Hospital, Inc., DBA University of Maryland Rehabilitation and Orthopedic Institute and University of Maryland Medical Center, LLC, submitted an exemption from Certificate of Need application to relocate 58 beds from UMROI to UMMC's downtown campus. These beds include acute inpatient rehabilitation, chronic care beds, and duly licensed acute inpatient rehabilitation and chronic care beds. The beds will be relocated to 4 floors being built at the top of the Stoller Center. Agenda items 3 and 4 are related. Maura Lawson, CON Program Manager, will provide an overview of the overall project. And then Rachel Burvell, CON Program Manager, will present the recommendation on agenda item number 3. All right, Rachel, you have the floor.
Thank you. So I do believe we have a slide. Okay, thanks. So the 2 projects being discussed today involve services that will be located in the new Stoller Center building that's under construction at the University of Maryland Medical Center in Baltimore. The construction of this building addition was previously approved to house the new cancer center. Agenda item 3 is the exemption from Certificate of Need request to move beds from the University of Maryland Rehabilitation and Orthopedic Institute to the Medical Center, and requires the construction of 4 additional floors. Agenda item number 4 is a second change after Certificate of Need approval to increase project costs and make changes to the physical plant design for that cancer center. So in this slide, you can see the building that is being constructed currently. It's also found in Appendix 4 in the report on the Cancer Center change request. The Cancer Center, shown in brown, will be located on the lower floors of the building through half of the 9th floor. Up until today, that's where the building ended, with just the mechanical penthouse taking the other half of the 9th floor and the 10th floor. But now, the rehabilitation unit, which is shown in green, will occupy that second half of the 9th floor through the 13th floor. And because of the addition, the mechanical penthouse will now be located on the 14th and 15th floor of the building. The renovations to the existing building are shown to the left of the Stoller Center. And we're going to keep this schematic up for you during these 2 presentations that you're going to hear, to help clarify the 2 projects, because it has been a bit confusing. So I will turn this over to Rachel.
Perfect. Thank you, Moira. Good afternoon, commissioners. The applicants in this review are the James Lawrence Kernan Hospital, better known as the University of Maryland Rehabilitation and Orthopedic Institute, or UMRY, and the University of Maryland Medical Center, UMMC, both hospitals within the University of Maryland Medical System. UMRY is an inpatient rehabilitation hospital that offers acute care, specialty rehabilitation, and chronic hospital care. They're located in Southwest Baltimore City with service lines including licensed medical, surgical, gynecological, and addiction, so MSGA beds, licensed acute inpatient rehabilitation beds, chronic hospital beds, and duly licensed chronic and rehabilitation beds. UMMC is the teaching hospital for the University of Maryland Medical School, located in downtown Baltimore. As a 710-bed medical center, UMMC is the largest hospital within the 12-hospital system of University of Maryland Medical System. The proposed project relocates rehabilitation services from UMRY to UMMC's downtown location to improve care delivery, patient outcomes, patient safety, quality, and access. The relocation includes 25 acute inpatient rehabilitation beds for traumatic brain injury, 18 acute inpatient rehabilitation beds for spinal cord injury, 5 chronic care beds, and 10 duly licensed acute inpatient rehabilitation and chronic care beds. The project expands on UMMC's Stoller Center for Advanced Medicine through construction of 4.5 additional floors and the renovation of existing space in the North Hospital. The exemption also includes 107,000 square feet of new construction, 63,000 square feet of renovations. And the project's total cost is $235 million, financed through bonds, interest on bond proceeds, and state funding. The applicants state that because the Stoller Center is already under construction due to the Cancer Center project, the proposed project can be completed in a shorter construction timetable, and it will result in cost savings due to buying materials at higher volumes, as well as mobilization costs for subcontractors. HSCRC also provided a positive review and opinion in support of the project's financial soundness, noting that the project will be financially feasible. Based on the review of the proposed project's compliance, staff concludes that this request for an exemption from certificate of need is in the public interest, it's not inconsistent with the state health plan, and it will result in delivery of more efficient and effective healthcare services. The project overall consolidates and relocates acute rehab and chronic care beds alongside trauma care and essential services that are located at UMMC. And it enhances access and convenience for patients that have multiple comorbidities while integrating specialized care for those requiring complex medical rehabilitation and chronic care. Staff recommends that the commission approve the exemption from certificate of need, as it will have a positive impact on the applicant's ability to provide acute rehabilitation services and chronic care. The conditions of the exemption are as follows. 1, prior to request for first use approval, UMMC shall provide information that details activities as it is undertaken to increase the amount of charity care provided to patients. 2, the applicant shall submit documentation of CARF accreditation to the commission within a year of opening. 3, any future changes to the financing of the project involving adjustments in rates set by HSCRC must exclude $8.3 million. And 4, the applicant shall document transfer and referral agreements prior to first use approval by the commission. Present on behalf of the applicants today are Sergut Adamasu, Leif Bauer, Dr. Andrew Pollack, Marina Bogan, Julie Niemans, and their legal counsel, Allison Lutic and Tom Dame. And there's also several people that are represented remotely and virtually via the Zoom.
Before we have discussion, I have one predicate question, and then I'm gonna call for a motion. But this is just a procedural one about what we're deciding between agenda item 3 and 4. They're two independent questions. Okay? Here, we're being asked specifically, and I don't want to worry anybody, because this is the sort of things I asked just so the commissioners know what we're deciding. Here, we're deciding whether or not the CON exemption qualified for it, sort of as an independent question from the cost analysis, the agenda item number 4. Do I have that correct?
Correct.
So I'll ask him, do I have a motion to approve the CON exemption for the University of Maryland Rehabilitation and Orthopedic Institute and University of Maryland Medical Center? Commissioner Boyle has made a motion. Was that a second, Commissioner Spinner? Oh, I'm sorry. I thought you said something. I didn't mean to put you on the spot. Sorry about that.
Me.
Any discussion or questions?
So is this creating new space that currently is not, is there new additional beds, or is just relocation of beds from other facilities to this facility?
Yes, so this is just the relocation of 58 beds from ROI to UMMC, and it will be on top of the newly constructed Stoller Center as illustrated on this slide.
Why wasn't this brought up when it was just a couple months ago that we went through approval for the CON for the cancer building? Why is this, a few months later, now it's 50% bigger? I don't know if you can.
So I think that's a great question that probably the legal counsel and the representatives can probably address. That's something that we also ask them. So I'll invite Ali Lutic to come up, talk a little bit more about that.
So as referenced here.
And I'm sorry, could you introduce yourself?
Okay, sorry, I'm Allison Ludich from Gallagher, Aviles Jones.
Thank you.
So these are two different distinct projects. There's the Cancer Center project that received its CON back in 2020 to construct the originally planned 9-story Stoller Center building. And then this project has been the result of a very long strategic planning process that OMS has undertaken as a system in terms of how it will deal with the delivery of rehab services going forward. So while the Cancer Center project has been under construction and there have been cost increases that have been brought to the commission through the project change, I believe back in October was when it was most recently approved, and then upcoming project change that will be decided in the next agenda item. This rehab project has been a separate strategic planning initiative. So this exemption application deals with moving those traumatic brain injury and spinal cord injury beds to UMMC to align them more closely with shock trauma.
So you're saying these rehab initiatives were a separate strategic plan, separate process, but we want it to be encompassed in the first CON that was given for a cancer center? What exemption from a new CON for this?
Correct, yes, an exemption.
Movement of beds is generally an exemption within a hospital system.
Commissioner Spinner?
So what's going to happen to the other building? And am I reading this correctly that is anything on the gray floors, on the grayed out?
There are, but they're unrelated
Okay,
to these
unrelated to
two
this.
projects.
Okay, so the 4 floors that are going to now be vacant on the existing hospital, what's going to happen to that space once you move the rehab beds to the cancer center?
Yeah, so as you can see on the schematic, the floors that we're dealing with are everything from floors 9, 10, 11, 12, 13, and then 14, which is the mechanical penthouse. Because we are now adding beds, the 58 beds from ROI, there will be a change in the FGI guidelines or the light guidelines for floors 10 and 11 of the older hospital. And so those beds will then be redistributed within the floors 10 and 11 of this new Stoller Center. And then floors 12 and 13 are the ones that are going to house the 58 beds that are being transferred over from ROI. And so that's how it will be laid out in terms of the floor plan and the distribution of the different specialties.
Okay.
That makes sense.
I think so.
Okay, hopefully so. Anything that's gray, however, is not related to this project.
Okay.
And what's the change in cost for this building, adding 4.5 floors?
So the cost for this, the total cost of this exemption project is $235 million, give or take. It's a little bit more
In
than,
addition to the cost of the cancer center.
in addition to the cost of the cancer center, which will be discussed momentarily, but yes.
But you're saying there will be cost savings because you'll be able to consolidate labor and buy materials in bulk by doing this project in addition to the cancer center at the same time.
Exactly,
Right,
exactly.
it's, you know, other choices would be possibly building something at another site or, and then, or building it at another time. At this point, if we do it at the same time and in the same building, it's the savings.
Okay.
Are there any other commissioners with questions? Just to clarify for the commissioners, so in this case, they're seeking exemption. They're not adding beds. They already have the right to have these beds. They have them in 2 facilities. And the reason we're coming for an exemption rather than a CON is that it allows, since there are no new beds, this analysis of is it in the public interest, are there savings, applies. You say you don't need, there's no need analysis because the need hasn't changed. Because there's no additional beds. Is that, am I stating that correctly?
Yes,
Okay.
for the most part, yes.
And for the most part. Feel free to elaborate for the part that's not the most
Yeah.
part.
Still went through the respective chapters in the state health plan to show that there was a need for transferring these beds over. But regardless, you were correct in that an exemption is just for the movement of beds within the same healthcare system. Yes.
Just one more clarification.
Yes,
So
Sergeant, I have a
the
question.
need,
Go ahead, Commissioner Spindler.
so the need for the beds is so they'll be closer to other healthcare services and therefore providing better care to those patients that are in inpatient rehab that have TBIs or other severe injuries.
Exactly.
Okay, got it.
Exactly. So now we are going to the Stoller Center, which is a trauma center, and also has the cancer center at the bottom and the rest of the UMMC greater community. And so these patients will now have all that care in one location. There's a lot of cost savings, reducing transportation from UMROI and bringing them to UMMC now that all these services will be co-located in one location.
Okay, thank you.
No, sir, did one of the commissioners online have a question or a comment?
Yeah, this is Commissioner Bandari. Thank you for what you're doing. I know how good service University of Maryland Medical System provides. My question, it's a really practical question. Do you have enough parking? Because patients always complain of parking. When you are going to add more beds, more services, hopefully there is a parking in the plan, right?
So I will actually call upon Richie Stever from, this should be remote on the line. Richie, do you want to address the plan for parking?
Yeah, good afternoon, commissioners. Thank you for your question, Commissioner Bandari. Yes, we did a parking study, and we realized that we do have enough parking to support the move of these 58 beds from the Humroy campus over to the UMMC campus.
Thank you. And for the cancer center also, because
That's
these
correct.
patients.
That's correct.
Thank you.
Good. Any last questions or comments from the commissioner? Yeah, I'll call a vote. All in favor of the motion? Say aye.
Aye.
Are there any opposed? Motion passes. Thank you very much. Sorry, Commissioner, I wasn't actually looking at you. And I wanted to thank the folks, I guess, actually, I shouldn't thank you yet. We should go into agenda item number 4. Agenda item number 4, CON project change. This is the second project change after certificate of need approval by the University of Maryland Medical Center for its cancer center projects. Construct the 9-story addition to the Stoller Center in Baltimore. The project change will increase the capital costs associated with the project and make changes in the approved physical plant design. Maura Lawson, who you heard from earlier, will present the staff recommendation. Maura, go ahead.
Thank you. So the request before the commission today is a second modification of an existing certificate of need to increase total project costs and make design changes to the 9-story addition to the existing hospital in Baltimore City. In August 2020, the commission awarded a certificate of need to UMMC, approving the construction of a 190,000 square foot addition to the North Hospital building. The project also included 40,000 square feet renovations. The total authorized project costs at that time were $194 million. In October 23, the commission approved a change after certificate of need approval to increase the cost of the project to $269 million and to make a number of changes to the physical plant design. UMMC is now requesting an additional cost increase close to $19 million and a further change in the physical plant design. The cost increase will be paid for with $10 million in cash, $8.7 million in authorized bonds, and $133,000 in interest income from those bonds. Regulations state that commission approval is needed before making a significant change in physical plant design and before incurring capital cost increases that exceed the approved capital cost plus inflation. The request today involves both a change in the physical plant design and a capital cost increase in excess of the inflation allowance, therefore requiring commission action. The commission may either approve the requested change, approve it in part or with conditions, decide not to approve the change for stated reasons, or require a complete certificate of need review because of the scope of the requested change. So the requested project changes are as follows. In the approved project, the mechanical penthouse, as I mentioned earlier, was to be located on the 9th and 10th floor of the new building. Because of the new floors being added, the mechanical penthouse is going to be relocated to the 14th and 15th floors. Additionally, UMMC is seeking approval for a further $19 million in project costs, which is approximately $11 million over the inflation allowance. The budget change is due to unplanned increases in the cost of needed relocations and renovations in the existing building. None of these increased costs are attributable to the University of Maryland ROI project that was just approved by the commission. Staff requested that HSCRC provide an opinion on the financial viability of the project, taking into consideration the proposed cost escalations. The opinion states that even with these increases, the project remains initially feasible and viable through to completion and for 2 years following the commencement of operations. Staff concludes that the project change is permissible. There are no material changes to the nature of the project, its location, or its core service capacities. The requested change would not alter the findings that the commission made in August 2020 or October 2023 concerning the need for and positive long-term impact of the project. Staff recommends the commission approve the proposed changes and issue a modified certificate of need to contain the conditions of the original approval with a change in condition number 5, which is as follows: that any future change to the financing of the project involving adjustments in rates set by the HSCRC must exclude $18,035,730, which includes the estimated new construction costs that exceed the Marshall Valuation Service Guideline and portions of the contingency allowance and inflation allowance. And just for the sake of brevity, I'll just say that the folks from UMMC have already been introduced by Rachel. So thank you, and any questions?
We'll start the discussion with the putting motion on the floor. Do I have a motion to approve the CON project change for the University of Maryland Medical Center Cancer Center?
I'll move.
Thank you. Do I have a second?
Dr. Bhandari.
Dr. Bhandari, Commissioner Bhandari, thank you. Just an initial question for the commissioners in evaluating this. When we're looking at the financial cost change, what is the legal rule we should be adopting? Is it the financial plan was feasible, or the project is feasible, or these are reasonable costs, or I'm assuming it's not just, I think this is too much money would be the wrong metric. What is it that the?
Well, we do look at feasibility and viability, and we ask that of HSCRC, we ask for their assistance with that as well. that is the big thing. Is the project still going to be able to run? What is the funding mechanism for this? Because that'll have a lot to do. So this is, in essence, not a huge jump. You know, the first change request was a much larger change. This is in the overall, you know, project, which is now including these two these two projects, it's more than $500 million, than an $18 million cost increase. You know, as staff was reviewing the project, they made a good case for why they needed it in terms of some of the renovations that they had underestimated what it would cost to relocate some of these facilities that they had to relocate. So that from the staff perspective, that's how we look at the project.
Thank you. Any commissioners with questions or comments? That, I'll call the question. All in favor of the motion? Please say aye.
Aye.
Giving a second for any late ayes. Are there any opposed? Motion passes. Have the CON change. Thank you, folks, for all the University of Maryland folks who came in today.
Chairman.
Yes, sir.
I just want to thank the staff for fantastic, thorough, and timely job as always doing these. And, thank you, commissioners, for your attention in reviewing. Love to see the consent agenda. That was a wonderful start to the meeting.
Thank you, Dr. Pollack. Come back anytime.
Congratulations.
Excellent. Agenda item number 5. This is certificate of ongoing performance for Ascension St. Agnes Hospital's PCI program. Okay, we're considering a certificate of ongoing performance application of Ascension St. Agnes Hospital to continue providing both primary and elective PCI services. Eileen Fleck, Chief for Acute Care Policy and Planning, will present the staff report. Eileen, you have the floor.
Good afternoon, Mr. Chair and Commissioners. I'll be providing an overview of staff's evaluation of the hospital certificate of ongoing performance. Next slide. The standards applied are summarized on this slide. Data collection refers to the participation in the American College of Cardiology's CathPCI registry. Patient-level data is collected that allows for risk-adjusted evaluation of a hospital's performance with respect to patient mortality and comparisons with other hospitals in terms of certain benchmarks for evaluating the quality of care.
Yeah.
Institutional
I
resources.
think the last couple of times.
Refers to requirements that include hospital
Yeah, I'm trying
to have staff and
listen to-
resources available to sustain the hospital's PCI program. It also includes a requirement that hospital have PCI services available 24 hours a day, 7 days a week. The regulations recognize, though, that in some cases, a lack of available services cannot be reasonably avoided. Quality standards include requirements for routine reviews of cases and monthly meetings to review any issues with the provision of emergency PCI services. It also includes requirements for external review of elective PCI cases and reviewing the performance of individual interventionalists. Hospital must also demonstrate that it takes appropriate action in response to concerns identified. Patient outcome measures includes requirements for meeting performance standards established in state or federal regulations. In practice, this primarily just means the risk-adjusted mortality rates for STEMI and non-STEMI patients is similar or better than the national average for participants in the CathPCI registry. Physician resource requirements include that interventionalists who perform PCI at hospitals without cardiac surgery on site perform a certain number of cases on average each year and participate in the on-call schedule. For PCI services, interventionalists are also required, with a few exceptions, to be board certified in interventional cardiology. Volume requirements include a minimum number of primary PCI cases to be performed each year and a target number of total PCI cases for programs with both elective and primary PCI services. These standards were based on the association between volume and quality in the literature reviewed at the time the regulations were adopted. Next slide. As shown on this slide, between calendar year 2020 and calendar year 2023, PCI services were always available, except for 3 instances when an interventionalist was not available. As noted in the staff report, we are recommending that the commission find the standard was met with a condition that requires some additional reporting in the short term so that staff will be timely aware of any lapses in PCI services. I'll read that condition at the end of the presentation. St. Agnes Hospital met the door to balloon time standard of 90 minutes or less over rolling 8-quarter periods for 75% of primary PCI cases in all periods except one between calendar year 2019 and calendar year 2022. The hospital explained that the COVID-19 pandemic contributed to many delays in door to balloon times in the 3rd and 4th quarters of 2020. Staff concluded that was a reasonable explanation. The last standard summarized on this slide is that a hospital shall maintain a risk-adjusted mortality rate consistent with high-quality patient care. Next slide. On this slide, you can see the hospital's risk-adjusted mortality rate for STEMI cases between January 2019 and December of 2023 was similar to the national benchmark across all reporting periods. Next slide. On this slide, the hospital, you can see, performed similar or better than the national average for non-STEMI cases between January 2019 and December 2023. There were 5 reporting periods when the hospital performed statistically significantly better than the national average. Primarily, that's around 2022. Next slide. As I mentioned earlier, a hospital is required to show that it takes appropriate action in response to concerns identified. The hospital demonstrated this by providing detailed meeting minutes that describe its actions. Also on this slide, next slide. With respect to volume requirements, the hospital is performing well over 200 cases of PCI each year. The hospital performed between 376 and 395 cases for the period from calendar year 2019 through calendar year 2022. For primary PCI cases, the hospital performed between 87 and 105 cases annually between calendar year 2019 and calendar year 2022, which is well over the minimum required volume of 49 cases. With respect to external reviews, the hospital provided the results of reviews completed for cases performed between calendar year 2019 and the 1st quarter of 2023. Staff's analysis indicates that over 5% of elective PCI cases were reviewed each year as required, and at least 6 cases per physician each year. The hospital also demonstrated that at least 10% of cases for each interventionalist were reviewed internally annually as part of reviewing the performance of individual interventionalists. Next slide. With respect to the meetings that must be held for case review and evaluating issues with provision of emergency PCI services, the hospital is holding these meetings as frequently as required or more, with the appropriate staff attending both. There was only one exception when there was no meeting in the month of April 2020, again attributed to the pandemic. Lastly, I want to note that the hospital is providing primary and elective PCI only to suitable patients based on our review of the CAP PCI data and the information submitted by the hospital. Next slide. Staff recommendation is that the commission issue a certificate of ongoing performance that permits St. Agnes Hospital to continue providing primary and elective PCI services for 4 years, with the condition that beginning August 1st, 2025, and on an annual basis until St. Agnes is released from this condition, St. Agnes Hospital shall report to MHCC dates and downtimes for its cardiac cath lab, including the start and end times for downtime, the reasons for downtime, and whether patient care was affected by August 1 each year for the 12-month period ending June 30th. At this time, I'd be happy to answer any questions. I also want to note that there are people attending this meeting online to represent St. Agnes. Those are Dr. Matthew Boss, the medical director for the cardiac cath lab, Michelle Hardester, the nurse manager for the cardiac cath lab and cardiology services, and Wendy Lincoln, chief nursing officer.
Welcome. Thank you, Eileen. So start with a motion. Do I have a motion to approve the certificate of ongoing performance for Ascension St. Agnes Hospital's PCI program for 4 years?
Motion.
Commissioner Kwasinski, thank you. Is there a second?
Second.
Commissioner Spinner. Thank you. Are there any questions or discussion? Commissioner Kwasinski.
I have a question. The second recommendation. The second recommendation, I don't recall seeing this before in other reports. It strikes me as odd that it's a specific requirement of this certificate of ongoing need that they have to report the downtimes. Was there a downtime event or multiple events that triggered us to make this requirement in here, or is this a standard requirement that I just was oblivious to previously?
Well, downtime is something that they report on and they track, whether it's for maintenance or other things that may come up. And so we are normally getting that information. And in this case, a physician was not available a few times. there is sharing of the on-call coverage between St. Agnes and University of Maryland Upper Chesapeake Medical Center. And so there have been some concerns at both hospitals in terms of having that coverage and making sure that there is a physician available. What happened in a couple of cases is that the physician was at the other hospital doing a case. And so no one could be at the, at St. Agnes because the physician on call was at University of Maryland Upper Chesapeake Medical Center. And so that's a bit of a concern in terms of having the coverage. It's a little bit unusual for it. The physician is not available to be the reason that you can't provide PCI. A lot of times it's something else. It's literally the equipment broke down, right? Or there was some reason that services can't be provided. So that's a little bit more concerning when it seems like it's within the hospital's control and it's a fixable problem.
So this condition is as a result of findings that there was unanticipated or atypical downtimes that were experienced.
Right, so we just want to continue to have timely information to see if it is something that is getting worse or if there's a trend in that direction and there maybe needs to be a little bit more done.
So what happens at the?
And this is
uh,
Dr. Voss. Sorry to interrupt. I just want to make it clear that there was one case in 4 years where there were 2 simultaneous STEMIs at one hospital and 2 at another hospital. And we were able to get a hold of the covering second interventionalist. But at the time we finally got a hold of him, we had made the decision to transfer the patient, and no patient was harmed in that scenario. The other 2 were only 2 or 3 hour periods where there was a physician who was sick and couldn't do his job. So I just want to be clear, it was not there's no trend. It was just 3 times in 4 years that we were unable to have a physician available.
Ms. Benner?
So what happens at the end of the reporting period in June 30th? You look at the results and then make an assessment whether there's additional reporting that needs to be done. Let's say it starts trending downward and impacting patient care, or are there other consequences at that point if it's not rectified?
Well, I think if it was similar, well, I think we could have asked for additional reporting if we had a concern. I think if we were concerned about the patient care, then that would be something where maybe we should be taking some action and doing something more if patient care is being affected. As Dr. Voss said, patient care was not so adversely affected that there was, a negative patient outcome like a death or something as a result of this. So that's good. I mean, I feel like that's why we have a condition. It's something we want to continue to have a little bit more information on timely, but we don't see it as something where there is a need to correct anything at this point because there was not a negative impact on patient care. So yeah, we do have some options in terms of continuing to report. If we think everything looks good, then we could say like, okay, that's enough. We'll just wait until your next application.
Okay, thank you.
Go ahead. It's, there's in the summary of standard, one of them semi-annual external reviews of at least 5% of randomly selected electives. And then if we go to the next slide, 8, primary and elective PCI is only provided to suitable patients. And there we get the statement that they were only provided to suitable patients. So in the first instance, can we hear a little bit about what that external review looked like, who did it, and what it looked like? And in the second instance, what is the basis for the statement that only PCI was only provided to appropriate patients based on information submitted? So in that second case, was there any external third-party review besides MHCC?
So in the first case, the external review of at least 5% of cases, that's something where it's just looking at the appropriateness of PCI for elective cases, because that's where there's more discretion, where maybe it should be done, maybe it shouldn't. There's been an issue in the past, as I think everyone's familiar with. And so someone, an interventionalist is looking at that in terms of the angiographic information. They have to see the images. That's a big part of it.
I understand all that.
Oh, okay.
I'm asking who did it.
Oh, so it was MACPAC. That's the external review organization that they use. And so there's a pool of interventionalists who are blinded to what hospital it is. That give
I'm
opinions.
familiar with them. Yep. In the second instance, what's the basis for the statement?
So there are expert guidelines about who is appropriate for PCI services. The concern on this has sometimes been, okay, for the patients in shock, are they, is it okay for them to treat them even though because that's the best scenario for them?
Again, I sort of get all of that. My
Uh-huh.
question is, who's looking at the data and making the judgment call that only, the PCI was only provided to appropriate patients? Was it MHCC staff? Was it internal staff at the submitting, and was it some third party?
So partly part of it has to do with if someone got thrombolytic therapy instead. And so I can see in the CAF PCI data, thrombolytic therapy and whether that was given or not. And then the hospital also reports on, were there patients that received thrombolytic therapy in lieu of PCI, and did that not work? And then
Again, so I'm asking but there's a judgment call here that's being made. And I'm just trying to figure out who is actually making that call. Is it your staff here at MHCC? Or is it somebody at the submitting hospital or some independent third party?
it's the hospital tells us whether there were any instances where someone was not suitable for PCI. So they tell us, this is what we found, this is our information. And then I'm looking at how many patients got thrombolytic therapy. Were there any that got thrombolytic therapy at all? And usually there are none, or if there's one, but that's well below sort of what's considered acceptable. And so I feel like it's the combination of those two pieces of information, but I feel like we are relying on the hospital to a large extent in terms of them saying, this is what's true for us and what we have to say about it.
Just a clarifying question, the standard we're talking about is the annual evaluation of individual interventionist performance. Is that the one we're talking about?
Page 8, the bottom on the left, primary and elective PCIs only provided to suitable patients. And I'm trying to get it. I mean, if they're self-reporting, I'm wondering if there's anything in our oversight that would allow us to ask for more than self-reporting on that. That's where I'm getting. If it is self-reporting, and I think that's the answer.
It helps us on the rocks.
Yeah, so I mean, I think in the staff report, it's easier to see. It's the page 24 is where it has suitable patients and it has who are suitable patients and it has the standard and then it has briefly what we concluded. And it is, as was stated on the slide.
Yeah, I get all that. It's just a matter of oversight, right? I mean, self-reporting is less reliable and less comforting than some third-party reporting. And so my question was, first of all, is this self-reported? And it sounds like it is. And then secondly, is there anything in our oversight that would allow us to say we would like to see more than self-reporting?
We can do
I've
an
heard the
audit.
answer might be no.
Well, I mean, we can do an audit of the data if that's something that's a particular interest or focus of the commission, we could do that. I was thinking that with the inpatient, the HSCRC discharge data, that it should be possible to see in that data too. I mean, again, that's sort of information reported by the hospital, but I would expect to be accurate in terms of what was the diagnosis, is the procedure showing up for PCI, for thrombolytic therapy. And I did try looking at that for one hospital, but it didn't seem like it was aligning with what they told me. And so I felt like I don't know exactly how to identify correctly those patients.
So it seems like on page 24, as you reference, COMAR explicitly defines suitable patients. Patients appropriate for primary PCI as expert guidelines in certain other circumstances. So you look at what the hospital reports and you see what they report, you compare it against the suitability standards in COMAR. Is that kind of the process?
I wouldn't say that because the guidelines refer to who's an appropriate patient. And so you'd have to be looking at the patient information, right? The clinical criteria, the clinical picture to see, does that match with the expert guidelines? So staff is definitely not doing that because we're not qualified.
So who does that?
Well, so in that case, we are relying on the hospital, right? I feel like in terms of that. But to me, a little bit of it is
Can I add a comment on external review?
also this issue of thrombolytic therapy, in terms of it's supposed to be less than 10% of cases, right? If PCI services were not initially available, they got thrombolytic therapy. So that's the part of it that I feel like staff can check because we can see who got thrombolytic therapy in the
Whether or
data.
not it meets the expert guideline criteria, MHCC staff does not make that determination.
No, we need clinical
And
experts.
so you rely on the hospital to say, yes, this met expert guidelines for PCI or no,
Right,
as the hospital reports to us.
yes.
But I'm just getting the clarification. So when we see here the statement that from 2019 through 2022, PCI was only provided to appropriate patients based on information submitted and analysis by MHCC staff. Really what we're looking at here is that's what the hospital told us and we believe.
Yeah, in terms of,
Can I ask a question though, because it refers to external review reports.
yes, so there's external review to look, I mean, that's another piece of it. So I feel like there are these two pieces, two standards, right? One of
Can I
which
just
we've
make
been
a comment?
focused.
This is Dr. Voss. Sorry to interrupt. I can't see where I can like hold my hand up to have a comment. Just to be clear, all of our PCIs, we enter into the CATH PCI registry, which is the national database, and we get a report based on appropriateness of each PCI that we do. So that for sure we know for all STEMIs, non-STEMIs, and elective PCIs, we have, for the last 10 plus years done that. And then with the external review, which is the MACPAC, that also uses similar criteria for appropriateness, which looks at lesion characteristics, clinical presentation, and angiographically whether it meets criteria. And so they evaluate each program based on that. So, and we also have our internal review that we review cases each week in a CATH conference, as well as quarterly and formal peer review, where it's a closed door kind of peer-to-peer review of cases. So that's how we evaluate this over time, and I think it works fine.
I appreciate the clarification, because then again, that sounds like there is at least some level of external review in each instance, right? There's comparison to a national database. Thank you.
Are there any additional questions or comments? Ben?
I did have one question. This is for the physicians and the other representatives at St. Agnes. In 2024, there was a major data breach at St. Agnes, led to the taking offline of the electronic health record and other applications. This is outside of the scope of the period for which we're reviewing performance, but for helping, we do play a role in monitoring breaches. And I was curious, specifically for the cardiac service, what were the implications of that data breach, and are there any lasting consequences to the your approach to maintaining information for patients who need critical care, such as PCI?
Dr. Voss, I'll take
Yeah, hi,
that for you.
This is Dr. Voss, yeah. So thanks for that question. And you'd have to ask Ascension as far as what data was breached. I'm not clear that there was really any data breached. I know there was a shutdown of the computer system, so we were offline from our computers for several weeks. It didn't have any impact on our ability to do primary or elective PCI, because it doesn't affect how our cath recording equipment works or the cath equipment. So I've been in practice long enough to know how to take care of patients before there was an electronic medical record. So we went back to days of paper and pencil and running paper to and from the lab. So other than seeming to take a lot longer getting information back and forth, as far as STEMI care goes, I was very impressed with the team at St. Agnes and my colleagues for getting sick patients to the cath lab and taking care of them in a very high level of skill. So that's all I can say. As far as the data breach, you'd have to talk to Ascension nationally. I'm not sure that there was any data breached. I know the computer systems were locked down to prevent that.
Thank you. And just follow up in terms of entering clinical notes with the system down, how was that actually accomplished?
Just like the olden days, we wrote it on paper, and then go to medical records. And as soon as the computer was back online, all that paperwork was scanned into the electronic medical record so that they could bill it. And then it was accessible, will be accessible in the future.
Thank you.
Any additional questions or comments? Commissioner Gilroy? I think your sound might be off.
Maybe if you could type it in the chat box.
I think she's muted.
Maybe if she can just type her comments in the chat box, since we're not hearing her.
As long as somebody reads it out loud for us here,
Oh, that's right, yeah. I think it'll pop up. Send it to someone else who's online and they can read it. And like back to the computer or something. Oh, over here.
if you want to put it in chat, we'll read it out loud in the room.
All right, there's a chat. All of the beds were and are regulated, right? No change.
That was from a different presentation.
Oh, sorry.
I remember seeing that earlier.
That was from the,
The previous.
Yeah, that was a while ago.
Item.
And I just leave up the chat box in case she wants to.
Okay.
Is that okay?
Yes, that should be fine. You didn't see anything new come through, Commissioner Gilroy, if you put something through. There you go. Hold on. If the clinical questions of appropriateness, I'm wondering if it is worth it to add the info from the registry or other place to make it clear that there was clinical appropriateness.
I have sometimes in a report included what's in the PCI report in terms of appropriateness. Actually, like looking at this again, reading over now, I feel like the purpose of this was actually that patients, hospitals that don't have cardiac surgery on site, they're not supposed to handle certain patients because they're considered like kind of risky and complicated and more appropriate for the tertiary institution. And this was actually put in place partly to make it acceptable and because it's in the patient's best interest potentially for the physician to just go ahead and treat a patient that normally they wouldn't under certain conditions. That normally the guidelines would say, don't treat this patient. They really belong at a tertiary center. But if the physician's judgment is, it's in the best interest for me to treat this patient as best I can here and not transport them, then that's acceptable. So I feel like the purpose of this wording was in that direction, preserving the patient's best interest versus this overall look at who's appropriate. But yes, I mean, like, as was mentioned, there is information in the registry about appropriateness. The reason we do the external review with the angiographic images is that people do feel like, well, that's essential. Having that to really know if it was appropriate for the registry, you're only looking at what is the information typed in. You don't have the images. And so it's seen as, well, you don't really have the full picture, but it is a picture based on what you can put in a registry. So.
Thank you. Any other questions or comments? That I'll call the question. All in favor of the motion? Say aye, please.
Aye.
I can see Commissioner Gilroy
Aye.
has her hand up as well.
Aye.
Are there any opposed? Motion passes. Thank you very much, Eileen. And thank you to the folks from Ascension St. Agnes Hospital. Good. Agenda item number 6 is a presentation on HIE validation and exemption requests. The General Assembly passed Chapter 249 HB 812 Health, Reproductive Health Services, Protected Information and Insurance Requirements in 2023, which prohibits the disclosure of legally protected health information by electronic health network and health information exchange entities operating in the state. MHCC's regulations became effective on May 13th, 2024. David Sharp, Director of the Center for Health Information Technology and Innovative Care Delivery, and Anna Gribble, Assistant Chief of Health Information Technology, will discuss vendor compliance requirements and the progress made in implementing these regulations. You have the floor.
Hey, good afternoon, Commissioners. It's a pleasure to be here before you today to provide an update. My colleague and I are excited to delve into this a bit with you more. So Anna's going to start off, and I invite our Executive Director as well to make any comments during the presentation.
Well, good afternoon, and thank you, Mr. Chairman and Commissioners. Next slide, please. So during the 2023 legislative session, the General Assembly passed Chapter 249, House Bill 812, Health, Reproductive Health Services, Protected Information and Insurance Requirements. So the 2023 law establishes protections for the disclosure of legally protected health information by electronic health networks, or EHNs, and health information exchanges, or HIEs. The law requires EHNs and HIEs to suppress legally protected health information by December 1st, 2023, and fines for noncompliance may be imposed beginning June 1st, 2024. Next slide. Next slide, please. Thank you. So the MHCC amended 2 sets of regulations in support of this law. Comar 102507, certification of electronic health networks and medical care electronic claims clearinghouses, and Comar 102518, health information exchanges, privacy and security of protected health information. Under the regulations, EHNs and HIE vendors are required to block codes listed in Comar 101108 to encompass legally protected health information, restrict text-based notes related to legally protected health information, as well as facilitate the exchange of legally protected health information to a specific treating provider when a patient provides consent. In addition, HIEs and EHNs are required to report to MHCC on implementation and compliance with the law.
And just to give you a bit of perspective on what it means on blocking the codes, there are roughly 19 codes that are identified in the Maryland Department of Health regulation, which is the 101108, that the electronic health networks and the health information exchange entities would have to block. Give you a bit of perspective on volume.
So in regards to reporting to MHCC, in January, EHNs and HIEs submitted either an affirmation of compliance in compliance with the law or an implementation plan detailing their strategy to filter and restrict legally protected health information. So at that time, almost all EHNs submitted an affirmation of compliance, as nearly all EHNs operate as a healthcare clearinghouse and only disclose legally protected health information for the adjudication of claims, which is permitted under the law. So those other entities who submitted an implementation plan also submitted a status report to us in April and a validation of compliance in June. Next slide, please. So to support entities in implementing the regulations, MHCC has implemented several different activities in their support, including convening several town halls to provide a forum for EHNs and HIEs to ask implementation questions, provide advisory support to health systems and HIEs, and we've developed EHN and HIE specific implementation guidance documents to clarify the regulatory requirements. We released these guidance documents in January and February and updated them in March and April, and then again in May.
And to give you a bit more perspective here, when each one of these town halls brought probably 80 to 90 different individuals to attend, when we first journeyed down this pathway, a lot of the health information exchange entities were of the mindset they couldn't do this and were seemingly resistant to even wanting to try. But as time progressed and we helped them work through what the requirements were, it appears that most of them were able to get on the journey, and many of them have made notable strides, which we'll talk about in a few moments, in terms of implementing the 3 different categories of requirements. We've also worked very close with the Electronic Health Record Association and its members to help educate them in what the requirements consist of and answer questions specifically related to their solution, as well as how they can approach working with their own clients. So we've done a considerable amount of outreach and gained quite a bit of traction, what we would think about as acceptance among the HIEs in the industry. And to just note, there are roughly 15 health information exchange organizations operating in the state. One of them is the state designated HIE, that you've heard. We heard Commissioner Budzinski talking about earlier. And then others are acting more as electronic health record vendors. It's quite diffuse, and as a result of this law, we've actually had 3 new health information exchange entities want to come into Maryland. So it is interesting to say the least, but we'll talk more about specific compliance.
Next slide, please. So from these town halls and from reporting to us, we have heard that most EHR vendors report challenges in implementing the necessary technical capabilities to prevent the release of legally protected health information, including difficulties in filtering and restricting the codes, the legally protected health information codes, identifying and suppressing text-based information related to legally protected health information, and implementing a directed consent process as permitted by law. So in addition to the challenges identified by the EHR vendors, provider organizations have informed MHCC that an additional 12 to 24 months is needed once HIE and EHN vendors make the technology available to install the necessary software upgrades and test the technology. So various health systems and ambulatory practices have highlighted apprehensions about deploying software without conducting a systematic review for potential deficiencies.
And this is something we've learned through the process, because what we didn't realize is that there's a huge tail, if you will, on software development when it comes to rolling it out to provider entities. And these user acceptance testing is very important. We heard from health systems and other providers the importance of allowing progression of time to have a methodical review of the solution itself, because of the concerns or the risks, if you will, to patient care, patient safety, if there's a deficiency that's overlooked, as well as the operations of the entire entity, because electronic health record systems have grown, and they include aspects of a financial system, of an ordering system, procurement, if you will. So there's a lot of elements to it, and that there's also, what we learned is that there's a schedule deploying instances. So by way of example, if an electronic health record vendor, this is a real scenario, released a version in February of this year, what we heard from some of the healthcare entities that they won't even get to that version until the fall of this year, because they implement them on a schedule and they do this through a series of testing. It's never release one, implement one, release one. It's release one, it goes into this sort of first in, first out bailiwick, if you will, and then the providers test it, and then they implement it. Sometimes they find challenges and they have to go back to the vendor to work through these deficiencies. So there's a tail on implementing the technology, and it's important to call that out, because that's out of the control of the HIEs, software developers, and the health information exchanges. They don't control that. And that's one of the questions or concerns we continue to hear, because there's a vendor, by way of example, who has rolled out some of the fixes, if you will, to support the law. And it won't make the pipeline probably until the winter or spring of next year in some of the client applications. So it's just a long tail, and we'll come back to why that's important to know in a few minutes.
And then another implementation aspect we wanted to highlight is that the Maryland Department of Health Regulations, which lists these codes, the legally protected health information codes, also known as that COMARTIN 1108 abortion care disclosure. These regulations were published in the Maryland Register in January as proposed permanent and are not final yet. We have been communicating with HIEs and EHNs on the status of those regulations, and we will inform them when they are final.
It is our understanding that the department plans to propose them sometime within the next 90 days, but we're not absolutely clear on that time frame.
Next slide, please. So a snapshot of where we are today.
So while the challenges to implement the law are greater than anticipated, some notable progress has been made by EHNs and HIEs to develop the technical solutions to comply with the statutory and regulatory requirements. Now, implementation timelines vary between vendors, and vendors have made progress in filtering and restricting the codes, with many anticipating having the capacity by the end of 2024. However, vendors need more time to implement the technology or policies to restrict text-based legally protected health information. And we heard that vendor.
Question about that. Just make sure I understand. So the medical records that are tied to a code and they might have text in them, but assume you have a medical record for just, I don't know, somebody's annual primary care visit. They said something like, I took mifepristone 2 months ago. I'm not sure if medically that's a thing you might say, but assuming you did and the PCP dutifully just wrote it down, would that be like the kind of thing that you would need to find and block?
So.
Even though it's not tied to a particular.
Not in order, it's not a
Reproductive health,
diagnosis,
right.
it's just language in there. That's
So
a good question.
there are a series of medical diagnoses in the regulations that Anna has mentioned, 10, 11, 08. And it has to meet the qualifier of having a specific diagnosis before a medication, just the issuance of a medication that may not be used to support reproductive health would be ordered or released.
They can start with the universal records that have the right, like, are going out of diagnosis as opposed to having to read all text, and all records.
It starts with the codes, so if it doesn't include one of the 19 codes, then it doesn't get picked up in terms of blocking.
Okay, that helps. Yeah, I was trying to figure the technical problem.
That's a good question.
Thank you.
And vendors have varied in their approaches to and blocking text-based and legally protected health information, with some of them looking to providers to market or flag the text-based information as well to suppress it.
And it's important to note that these vendors don't all use the same approach, blocking the information. It's so variable that's partly why you see long date ranges of the technology, because they're not all blocked the same. There's different ways of treating the information, and it's as though it's customized in each of the vendor's solutions. So unfortunately, there isn't a standard that you could say, okay, here it is, let's go through the order of it and make it happen and we're done. It doesn't work that way. It's much more complex because these systems were never designed to be retrofitted in the way that this law requires them to do. They're a mover of information. They're not a filter or a blocker. And they've been challenged to do that. And they're doing it and they're meeting the challenge, but it is re-engineering what these health information exchange organizations were designed to do.
So in addition to the codes and the text-based information, vendors also need additional time to develop technology or policies to then disclose legally protected health information to a specific treating provider when a patient provides consent or a parent or guardian of that patient provides consent, which was a permitted allowance of disclosure under the law.
So there are the technical requirements and then the policy requirements. And so it adds another dimension to this work because there's policy that gets trickled down from the vendor to the client, because the vendor is responsible for blocking, as Anna has talked about, and restricting certain elements related to these codes. But in all cases, it's not a technical fix, and it has to be supported by a policy fix. And that too takes time, because what the vendors will say is they have to work in a very different manner because they can't renegotiate all their contracts with their clients to support the law. So it requires some creativity among the providers. It requires educating the providers to make sure they're aware of these requirements and gain acceptance of it. The last thing I would note, and then because I may be answering your question, is that remember that the responsibility is on the HIEs. It's not on the providers. So it leaves a gap, if you will. And what we hear from the HIEs is it could work more expeditiously if there were some requirements on providers.
That's something I would like to never see happen. with all the other things that go into a patient care encounter, trying to flag whether or not my scribe wrote down mifeprostone in the HPI or progress note, and then having some sort of legal liability and financial penalty if I forget to flag that to the HR, that's a no-go for healthcare providers. That's too far, and I just would strongly oppose that with all resources I have, should that be a direction that these vendors choose to go, or that they try to off-put their responsibility onto the providers. That would be.
And we've heard that a lot, and I think that there's no question that that's not a common theme. But I would share this with you in the spirit of transparency, that California has a similar law. And they have a requirement on the providers that starts in January 1st. So there is one state that has found a way to do that, for better or worse, but I just want to make sure you're aware of that.
I live in Maryland.
This is not an action item. I think you had another slide.
Yeah, just a few more, but to speak to the timeline that's on this slide. So this timeline reflects when we anticipate vendors will have the technology in place. Just as a reminder to what David said earlier, we've heard from providers that there's this tail. So we have an anticipated timeline, but it could still be an additional 12 to 24 months for providers to then update their software and implement the new technology solutions vendors have created. And then finally, so as we mentioned, once COMAR 101108 is final, they're currently proposed. Once they're final, the MHCC will consider vendor exemption requests related to legally protected health information requirements. And during the interim, we've asked vendors to provide status reports, biannual status reports to us beginning September 30th, 2020, or this year, September 2024, on their efforts to continue to work to be compliant with the law. Next slide, please.
Can I ask you a question? So is this that the vendors on this list only, because there are so many vendors? Small practices, primary care practices have a very small vendors. So I see these are the bigger vendors who are mostly working with the big practices or the hospitals.
So there are 15 Commissioner Bandari vendors in the state that meet the definition of an HIE, which is defined in statute. So it isn't just any electronic health record solution, because some of them are tethered to the large guys you saw on the list. But you have to meet that definition that's defined in statute. So yeah, there are many electronic health record vendors nationally. Those 15 happen to be electronic health record vendors, but also function as a health information exchange, which is where the market has been moving. Because if you recall, originally, there were only these organizations like CRISP, where their business model was to function solely as an HIE, moving patient information. Then the electronic health record vendors began to evolve into that space as well. So inevitably, over time, probably all or nearly all electronic health record vendors will be in that space.
Thank you.
Speaking to next steps, once COMAR 101108 is adopted, staff will consider one or more of the following based on the status of vendors' compliance. Either delay vendor fines for non-compliance with the regulations for at least 12 months, or impose fines on vendors for non-compliance with the regulations. And staff will review options at the September meeting. So in addition to staff will monitor implementation and compliance activities and continue to submit quarterly implementation updates to the legislators as required by the law. Next slide, please. So thank you, Chairman and Commissioners. This concludes our presentation, but we're happy to answer any other questions you may have.
Commissioners, are there any questions?
There are fines imposed. Is that something that comes before us to vote upon, or is that something that's automatically imposed by staff actions?
So the fines are in the regulation. We would, so having not done this, I may need clarification from our executive director, but we would assess the fines and note them to the commission.
that would be appealable to the commission.
So the staff might assess a fine and an HIE just pays it. Or an HIE could come to the commission and say, this fine is not appropriate.
They could oppose, they could ask to appeal it, and then they would come before the commission.
One question, and this might be a small matter, if a record is blocked, does a provider getting records to the HIE have some flag that there is a record out there? You need to get consent if you want to see it, or is it just, there's no such indication, and the provider would have to talk to the patient to see if there were such records? Does that question make sense?
Yeah, no, I get it. That's a good question. And it gets back to one of the things I mentioned earlier about there being no standards, if you will, around how the vendors implement these requirements. Some of the solutions will indicate that the provider's not seeing a full record. It doesn't tell you what's blocked, but in those instances, as part of the training to providers, they'll ask the question. They'll say, look, your medical record doesn't include all the information. If there's something else that you could share with me, or do you want to explain to me what it is? Or they might say, have you ever had this or that? So there's some indication. There's usually a flag that goes back to the individual doing the inquiry into the system, that it's not a complete record. We haven't seen it demonstrated, so it may not always be a flag. It may be a note on top, of the header of the record. But from what we're hearing from the vendors, they are trying to make it clear that you could be looking at a partial record. And this will happen, by the way, what our executive director mentioned, the consent management application that we're working on developing. Once that gets to the level of granularity, it's going to be broader than just the reproductive health issues. It could be whatever the patient chooses to block. But the indication would be to a physician, the patient has chosen to block the record, and it requires some engagement there.
Thank you.
David, that's really concerning because physicians are limited time. Now they have to go through whether you block something or not. It's really contradictory what the government is doing. So nowadays, patients get the reports of their test immediately as soon as it's done. Sometimes I don't even have a report. They get a text and they say, well, I have a CT scan which is red, and now they are blocking. I don't think, it's probably time for many doctors to retire. I'm listening that this is very, very concerning. It's going to be a burnt out for the physician, which is already happening.
So I think, I think that Anna and David may have emphasized this, but it's important to emphasize again that information exchanged within the same instance of an EHR implementation would not be affected by this legislation. So consider Epic is used by Hopkins University, Anne Arundel. They have, to the best of my knowledge, those would be 3 separate instances when they shared information. That information would be blocked. However, within a single instance of Epic, i.e. at Hopkins, internally, you see a primary care practice, you see a OBGYN practice. That information would be shared without limitation within that health system. But it would be a physician outside of Hopkins, say hypothetically, within the same vendors, or a different vendor, if it was shared at that point, this law would come into effect. Every EHR vendor has some implementation strategy for integrating records across provider site. Oddly, Epic, it's tools they have our care everywhere, and another tool that allows patients to authorize sharing of information called Happy Together. Epic always chooses cute little names, but Cerner and some of the other big vendors likewise have this capability. That's where the statute would come into play when that information is to be shared across provider groups. Independent of one another. All right, David?
That is correct.
How are patients going to be made aware that part of their health record is blocked from exchange? You know, because I mean, I don't think patients are following the actions of this commission and the, you know, policy that's being placed, and they'll show up and say, what do you mean? You know, part of my record's blocked? What do you mean? I never blocked anything. And, you know, and providers probably will have difficulty remembering which parts of the record are blocked automatically without patient consent, as in this law. So is there any, how will patients know that should they receive a prescription for mifeprostone that's blocked from other providers seeing it?
So there's certainly an education aspect, which is partly what we talked about. That clients of the vendors have to do a better job or have to increase their efforts on education and awareness. What we've heard is that patients receiving reproductive health, depending upon where they get that information, they're well educated on what happens to their information. For example, Planned Parenthood, even before this law came into existence, they would tell their patients, we do not share any of your information, block. Other organizations providing reproductive health services also have similar protocols around that. I think where your question comes to light is once the consent management application is up and running, to make sure that patients, consumers are well educated in what it means when they block their information. Because perhaps a consumer understanding the magnitude of it, which Dr. Bandari was noting, may say, oh, I don't want to block it. I thought I was just blocking it for this purpose. So ongoing education is not going to end when it comes to electronic health information.
David, I have patients when I see them, 9 out of 10 tell me, I don't know my medical history. Look at my primary care records. It's going to be a disaster for healthcare.
Yeah, but
I can tell you, you know, I practice medicine day in, day out. Can send me a patient and patient doesn't want to fill the paperwork. I have 4 pages to fill. They don't want to fill. They say, look at my primary care. Don't you have access to my primary care's record? Look at those ones. They have all the information. I don't know what medications are.
Absolutely understood. I hear that.
We have an online question and comment in the chat.
Oh, go ahead. Read it. I just want to comment that though I understand that smaller vendors may not be HIEs and may not have to participate or participate right away, or our healthcare system is so fragmented already, and this is again a non-standard application of requirements that will not help fragmentation. I wish we could design for the outcomes we are striving for. Thank you, Commissioner. Well, thank you very much.
Thank you.
Brings us to agenda item number 7, professional services report. The Maryland Healthcare Commission is required under statute to report on expenditures for privately insured professional services utilizing the Maryland Medical Care Database, MCDB. This report investigates the variability in payment rates for professional services in Maryland and compares private payment rates to those of Medicare and Medicaid for the same set of services. In this study, we estimate what Medicare and Medicaid would have reimbursed using their respective fee schedules for the same services paid by private insurance carriers. As in past years, this report will focus on in-network services only. Another note that this is tied into an issue that we'll see again in the fall. We have several other reports the Commission will complete on payment rates over the next 6 months. One includes comparing payment levels for telehealth and audio-only services relative to in-person payment rates, and another examine the adequacy of payments for behavioral health and primary care services. The chair of the House Health and Government Operations Committee has requested 2 additional studies related to payment rates. So the state is moving toward value-based payments. Fee-for-service remains the predominant payment network framework and is of concern to both payers and providers. Xu Zhu, Program Manager of Cost and Quality in the Center of Analysis and Information Systems, will provide an overview of the report. And I hope I pronounced your name correct.
Shuju, that's correct.
Welcome.
Shuju. Yeah, you pronounce it
I
correct.
got it right. Thank you very much.
Thank you. Thank you, Chairman, and good afternoon, Commissioners. I appreciate the opportunity to present the 2022 annual update on payment rate variations among private healthcare carriers for in-network professional services on behalf of the Center for Analysis and Information Systems. Next page, please. Next slide, please. MHCC is required to report on expenditures for privately insured professional services annually. In this analysis, we explored data spanning from 2020 to 2022, obtained from the MCDB, which is the Maryland Medical Care Database, managed by our vendor OnPoint. The analysis was performed using SARS. Regarding the study specifics, our research focused on individuals under ages 65 years old enrolled in private insurance plans, limited to in-network services only, which constitutes 99.97% of total relative value units. Market share includes large private payers versus other private payers. Large payers means the major private payers such as CareFirst and the United Healthcare, which collectively represent more than 80% of total expenditures. Private payment rates are benchmarked to Medicare and Medicaid. The rates are from Medicare, are from CMS Medicare and then the state Medicaid. Relative value units measures the quantity of care assigned to services. We examined variations in payment rates for professional services in Maryland by private payer market share. Next slide, please. In 2022, the payment rates for all payers combined was 39.32, which is the dark blue bar on the left side, up from 38.14 in 2021, which marks an increase of 3.1%. The increase was driven by increases in other payers' payment rates, which is the dark blue bar on the further right. Notably, the payment per RVU was consistently lower among larger payers across all 3 years, which is the middle charts, the middle bars. Next page, please. The rates vary across different regions of Maryland. Providers in DC metro area received the highest payment rates than as compared to other providers. This pattern is consistent with payment levels in the Medicare physician fee schedule, which is highest in the DC metro, lower in the Baltimore metro, and then the lowest in the rest of Maryland. Next page, please. The payment rate for services reimbursed by all private payers are somewhat higher than what Medicare pays. which is 8% higher in 2022, 1% higher in 2021, and 3% higher in 2020. Other payers' payment rates increased significantly, which may suggest that small payers face challenges in sustaining their physician networks. So leading them to raise their rates as a response. Next page, please. We see notable disparities in payment rates between services reimbursed by private payers and Medicaid. In 2022, private payers reimbursed services at an average of 18% more than Medicaid, rising to 26% more in 2021, and 21% higher in 2020. The trend holds true for both large and other payers. Next page, please. So first, payments per RVU for all payers increased by about 3.1% in 2022 compared to 2021. Secondly, the private payment rates for 2022 were about 8% higher than Medicare fee levels and about 18% higher than Medicaid. Compared to previous year, private payments were about 1% and 1% higher than Medicare and 26% higher than Medicaid payment rates. Last but not least, private payment rates in 2022 varied by geographic region in Maryland, with the highest in rates in DC Metro. Those differences largely align with differences in Medicare payment rates among the DC Metro, Baltimore Metro, and the rest of the Maryland regions. This concludes my presentation today, and I'm happy to take any questions you may have.
Your sergeant had to step out, but just are there questions? I have one in terms of, there does seem to be some unexplained variation from year to year, particularly in the other payer category, which is, smaller payers, but does include large national payers, including Aetna and Cigna, which in the Maryland market, don't have a large presence. They would hardly be characterized as small nationwide, but there's quite a bit of variation between 21 and 22. Maybe this is a question for Shankar. Why do we see that? What could be possible explanations? Generally, if you look at things like changes in the Medicare Economic Index, which generally increases are triggered off of some factors such as underlying medical inflation, that's not growing at that rate, but we're seeing some jumps, particularly vis-a-vis Medicaid. What does that say to you?
Sure. Thanks, Ben, for the question. Yeah, so when we try to dig deeper on to better understand why this variation in 2022 was significantly different than what we were seeing for the previous years, one thing that really stood out is 2022, when we had received the data from all those small payer or other payer category, which comprises mainly of Aetna, Cigna, and few of the TPAs. We noticed that there were a lot of resubmissions that had to be done. And because of that, the data, what we have really in 2022 stood out, and we ended up requesting the payers to resubmit the data for us. So the reason why we are seeing that 2022 stands out is mainly because of that, the resubmissions and the data issues that we had for that particular year.
I thought I saw in one of the preliminary slides here for some of the first drafts of this, I thought I saw a graph that had all the states on a red bar graph. Where did that go?
Yeah, so we, at the last minute, we decided to not to include that because of the data that was used to create that report was from 2017. So because it was from almost 7 years before.
Oh, that wasn't current.
Yeah, it was not a current data that was used to analyze. However, when we researched to find something which is more recent, we did find a research that was done by Milliman. They published a fact sheet in last year, 2023, where they looked into the similar analysis of comparing the Medicare rates with the commercial rates, and they have used their own proprietary adjustment tool to look into that comparison. And based on that fact sheet, they also made the similar conclusion what was reported by HCCI, which is there is a wide variation across the states between the commercial and Medicare rates. And when we try to rank the individual states, Maryland always comes at the bottom, where Maryland is one of the lower ranking states in comparison to commercial and Medicare. So the conclusion.
I know that firsthand with my own practice. So if you could, that's very helpful information, I think, just to give perspective. You know, as we look into this AHEAD model, we're looking at physician staffing to, provide care for Marylanders, and that's a big factor. I mean, I can move to, Georgia and get a 50% pay increase based on that data, and so why would I come here? And that's a hard sell to new physicians, quite frankly. Why would you come here? And so, I think that information is, valuable. And, perhaps in Maryland, the AHEAD model, we want to look at some, quality and outcome incentives as we shift healthcare funding from fee for service, running on the gerbil wheel of see more patients, make more money, to achieve better health outcomes, make more money. But I think that could be something that could be used strategically as we look at the AHEAD model, and as we look at some of these spend targets for primary care. I know in my own personal experience with MD-PCP, as well as some Medicare shared savings programs, that having real meaningful quality incentive awards and shared savings awards, it changes the culture of healthcare in the exam room, in your practice, in your organization. And those, I think, could be some effective tools. If we implement them well in the AHEAD model, we can meet our state primary care spend targets. We could also improve patient outcomes. I think we could provide encouragement, incentive, and true financial incentives for at least in primary care, as well as in other aspects of healthcare that reward quality, not volume. But maintain low physician reimbursement and expect to improve the care in this state without, in some other way, incentivizing physicians to practice better or to just frankly come to the state, we're going to be frustrated and failing as we try to implement this AHEAD model. So it's a long answer. It's a bit of a soapbox. Thank you very much for listening to me. But that data, I think, is very, very helpful. And I think one of the ways we could look at in the future, if we're a progressive state, looking at alternate payment models, we have many in the state. Okay, here's what we have from pure fee for service, but as we shift towards alternative payment models, what's the real impact on the physicians, physician reimbursement, fee services?
Absolutely, Commissioner. So point well noted. So we'll add that information in the appendix, and we'll also try to add some more information from the Milliman report that we have.
That'd be very interesting. I didn't realize how old that other data was, but I understand now.
And kind of balancing this off, this is a mandated report, but we have like 3 reports that are coming out that are going to look at this very same question.
Okay.
So I told them to take it out because we didn't want to step on our own headline. We're doing things more recent, comparing primary care, payment adequacy, behavioral health payment adequacy, et cetera. And we also have this market concentration study where we're going to be relying on some of the transparency data assembled by CMS under the No Surprises Act, which will be able to benchmark payers across the country relative to Maryland, I believe. On a more accurate basis, payers are reporting their fee levels on several times a year. I can't give you what the trigger is, but I think that's probably more timely and relevant. Please don't go to Georgia, however. The uninsured rate in Maryland is about 5.5% to 6%. In Georgia, it's 12%. And, you may get paid a little less here, but you'll get paid nothing by a smaller percentage of patients.
And
than you would, Georgia.
I do want to advocate that the Medicaid rate, which is about 39% of my practice is Medicaid, is much more favorable in Maryland than in some of the surrounding states. So that is appreciated, although I think there's room to move if we really want health equity for Medicaid recipients.
So Ben, I have a question. Don't move to Georgia, move to Virginia, 20% more just across. So Ben, this presentation, this is for whom? Are you going to show this to the legislators? I'm not very clear what to make out of that. If you show to the physician, they will be frustrated. They will pack the bag, move to Virginia or Georgia or some other state. This is very, in day-to-day when we provide the care to the patient, this is.
I think some of the more pointed policy reports are going to be more, on point. This is more of a descriptive study of what is, as opposed to coming up with any recommendations. Stay tuned on that. I'd also note two things. One is that this does not currently include Kaiser because so much of their services are paid on a capitated basis. We did have a success beginning in 2023 in getting them to put pseudo prices on their healthcare encounters. So in future years, they will be included. We'll figure out they are actually, in terms of market share today, particularly in the individual and small group market, larger than United's market share. So we may swap them out. And lastly, although this probably doesn't make a whole lot of difference this year, but we do issue a report, is that the non-claim based payments that physician practices receive are not in this analysis. This is all claims, which is still the vast bulk of what compensation is. But we need to figure out how we roll that in as value-based payment becomes
And
more of
does
an
this
option.
exclude self-insured products or whatever, companies that self-insured?
It includes government self-insured products by and large, except for the federal government, but it includes state employees. But my experience is that self-insured are renting fees, both provider networks and payer networks and payer fee schedules. So if I contract, and Sheriff Sargent may have something to say about this. If I contracted with not with Sargent, but with Care First, the fee schedule I would get would probably be they probably have a couple alternatives, PPO, EPO, but it's their standard fee schedule. I don't know if the chair has anything to react to that or not, but that's my understanding by and large. There may be some minor.
It is, except that some of the large commercial carriers also have multiple networks. So very large self-insured plans might go with a carrier, like a big national carrier with a narrow network, which will have a different set of arrangements from their broad commercial network. So insured products are going to have a broad network, and there might be different arrangements. But by and large, that's true, though. I think self-insured plan. Go ahead.
Does this data include service providers that are employed by healthcare systems?
It includes all the providers, yeah.
Thanks.
Any other questions or comments? Thank you.
Thank you.
You need a supercomputer to do it, but I would love to see a map of Maryland versus other states and all of the categories of payment where they stack up, so you can see the whole balloon animal all at one time.
I agree with that.
I think the goal is the second study on market concentration to look at that specifically falls out to the legislature's desire to see how payment rates in Maryland compare to other states as our physician commissioners, know that there are more attractive rates in some other states. I'll take into account other factors.
Yeah, I think getting the whole picture is really helpful to have effective discussions on planning. Because you get one snippet of it, you're right, you see one snippet and it looks horrible or it looks tremendous, depending on your perspective.
Well, we've come to the last agenda item number 8, overview of upcoming activities. Ben, do you have any upcoming activities?
So, yes, we have, so keep in mind that as of right now, we have no meeting scheduled for August. It would be the chair's determination. There was an item that suddenly came on our agenda that needs to be dealt with in August. That's happened a couple times during the pandemic period.
It happened last year.
Yes.
We had like a very short.
We had a
conference call.
hospice merger that needed to be covered because of the closing date of the deal. But we try to avoid that. In September, which would be the next regular meeting, we already have 9 agenda items, including the certificates of ongoing performance. We'll be, talking about, given there are a number, how to put those together in a way that is most understandable to the commissioners. We also have a presentation from the Maryland Patient Safety Center. As you recall, they get $1 million in funding from the Healthcare Commission, and they were given in the legislative session another $1 million for workplace violence initiative. Since the session ended, and actually as a result of public works action earlier this week, the governor, treasurer, and the comptroller, among other actions, cut $250,000 from that $1 million award to the Patient Safety Center. I'm not sure if that's on an ongoing basis or for 2025 only, but we'll have a presentation from the executive director of the Patient Safety Center.
Excuse me, maybe I misunderstood. 250,000 was from the second award, not from the ongoing.
Correct. I mean, we think that it's disappointing, but the state's finances are in a more difficult situation right now, and it's understandable that they would want to make take some opportunities to generate some savings. We'll also have an update on the healthcare associated infections work on Teresa's team. I expect we'll also be giving you minimally an update on some of the reports that are due in the late fall, consistent with the commissioner's chairman's request at the start of the meeting. We'll put all that together so you have a opportunity to see your workload ahead. I also wanted to take the opportunity to let commissioners in attendance know that I had earlier today alerted the secretary and others that I plan to retire in January of 2025. I've been here with Commission 30 years. It's been a high point of my career, certainly. Never planned to be here 30 years. Time does fly. I really appreciate the leadership from the commission itself, this chair, as well as his predecessors, this commission, as well as your predecessors. But most importantly, I want to recognize staff for oftentimes difficult but noble work that they accomplish. Certainly, oftentimes I've stood on their shoulders and got credits for things that I had very little to do with, but I think oftentimes they don't get quite as much credit as they deserve, but they are all very hardworking and dedicated and committed to the work of the Healthcare Commission. And lastly, we could not do this without the aid of some real strong legal talent, both Alexa and Caitlin, although here not here for so long have made enormous contributions to the legal framework and focus of the commission, but in terms of the confidence that they instill in the advice they give to staff and the commission. I hold them in the utmost respect. Trust them a great deal. So thank you. More to come. I think that we will meet internally. The commission hires the executive director. There'll probably be some need to convene the commission over the next month or so to talk about with the attorneys and perhaps Richard and Diana on how we would go about recruitment. I obviously would step away from that process, but it will take some time. I would think well, I don't want to speculate. It's your call on how you would proceed on recruitment, but it's the commission makes the determination. Naturally, there is input from from others in state government, but I would encourage you to hold that authority close to you because it is an important role and it's the person you have to work with. If not, just certainly think it's your decision and no one else's. Thank you for hearing me today, and I'm still going to be around for 5 months, so I'm not going anywhere. I don't think, but certainly, I am looking at a shorter time horizon.
You're the best.
So big news.
Yeah.
Well, bravo. Thank you for everything you've done so far. And we expect you to continue.
And I intend to through the duration of my stay here. Absolutely.
I'm not allowed to leave until he finishes writing all this reports.
That's why he's leaving.
So there will be, this is also, in terms of the date and the timing, news to me as well. I'll talk with our attorneys about the process. We'll have a discussion with the commission. It's, about how that will look. My term ends in September, although it might be a holdover. So we will build a process that is not dependent on me, right? So we'll have further discussions about that. In case you're wondering, what's going to happen? Let me get the grounds of possibilities, and then we can have a discussion.
Is that possibly a topic for an August meeting?
Well,
I mean, just to consider.
Or early September, or.
I think informal or not informal, but a commission meeting held virtually to cover some of the technical aspects and the process could be done at a convenient time in August or early September prior to the September meeting. I think.
Yeah.
Do we have a successor lined up for you in September already, or is that a decision that needs to be
The
made?
governor appoints the chair.
Yeah,
So we will,
perfect. But the governor has not as yet
correct.
appointed a chair.
And look,
Yes, not.
and then my position, for any of us, you can serve as a holdover commissioner until the subsequent commissioner
Got
is
it.
appointed, and I am happy to fill in the role until it's replaced.
I'm just thinking out loud, it would be more difficult if both slots were empty.
Yes, correct. That's correct.
Anyway, we'll
Is there any additional business, or shall we adjourn for this time, pending our to be scheduled follow-up meeting? Any motion to adjourn?
Motion adjourned.
All right, thank you, everyone.
I gavel it, and we're done.
That's-
Thank you.